Hello, welcome to Yorkshire Fertility Patient Information Evening. So we would always like a feedback about our evening and we want to continuously try to improve it. So I would appreciate if you could follow this presentation by giving us a feedback by email. Okay, so I'm Mr. Lakshmikant Chowdhury and I am the consultant in Yorkshire Fertility. We have a new team of consultants and we are starting these patient information evenings from this month. And we look forward to speaking with each of you and answering your queries along your fertility journey over the next few months. And we plan to organize these every 6 weeks. So hopefully we look forward to those interactions with all of you. And our anticipation is that this makes your journey easier because it's a lot of technical things which you need to go through and understand. So I'll be doing a brief presentation on IVF treatment. And we will also go through the embryology side of things where Marni, one of our embryologists from Leeds, she is going to speak about embryology. We will go through the nurse's point of view and understand the prerequisites prior to starting IVF treatment. And we would also look into a patient experience so you can understand how it is from your viewpoint as you go through this journey. And towards the end, I would ask that if you have any questions, you could type in the chat box so that I can read out the questions and answer them to help you out. So Yorkshire Fertility, we are one of the largest satellite units in the United Kingdom, and we do around 500 cycles in a year. And the area which we cover extends from Halifax, Huddersfield, Bradford, Dewsbury, Pontefract. So we do cover a large area. And our team includes Dr. Susie Jacobs. She is our new clinical lead who will be joining our unit from the 1st of June. Myself, Mr. Chowdhury, we have the male infertility specialist, Mr. Rogowski, and we have two consultants from Airedale. They are both fertility specialists, Mr. Nalapetta and Dr. Bhuya. So they would be clinicians who would be coming on Wednesdays and Fridays to support the unit as well as do clinics and scan sessions. So we have a wide range of team to help you out during your journey. We have our clinical lead, Helen Marvel, and you might have seen her at various points during your journey, and our scan nurses, Susie, Michelle, and Gemma. So they will be the people whom you will be interacting with. So Susie is the lead for donor sperm treatments, and Gemma is the lead for egg donation program. So at various points, you may end up interacting with them when you come for your treatments. We also have a upcoming band of nurses, which include Emma, Daniel, Nadia, and Heidi. So these are the nurses who are progressing through their fertility careers and training to be scanners and fertility specialist nurses in various fields. So you will be interacting them at new patient appointments, at your paperwork appointments at various points. We also have our business manager, Sue McCabe, who does the admin part of looking after the IVF treatment cycles. We have Helen, our lead for IT, and we have our receptionist Amy and our healthcare attendant Claire. We also have a team of counselors, as fertility is a long emotional journey, and at various points, if you need help with counselors, feel free to call up the reception and book an appointment to see one of the counselors. So these counselors provide support to the unit in the evening times to help arrange counseling sessions at various parts of your journey. Now, what is satellite IVF or ICSI treatment. So the advantage of a satellite IVF unit is that all your appointments for your scans, new patient appointments, blood tests are done locally in the satellite unit in Halifax. We are located at Broad Street Plaza. So this minimizes the travel disruption to your lifestyle. And then once your follicles are ready and you're ready to go for egg collection, you will need 2 visits to the central lab, which could be in Leeds or Manchester, depending on which lab you choose to go through. The first appointment of these is for egg collection, and the second appointment will be 5 days down the line for the embryo transfer. So these are the 2 minimum appointments which you need to do at the central unit. Subsequent to that, all your appointments after the transfer will again be with us in Broad Street Plaza, Halifax. We also have a collaboration with other labs like Care Sheffield and Manchester Fertility, and they offer various services which include sperm donation, egg donation, and it is for your convenience because there will be some certain services which are centered at a particular lab. So this is for the benefit of the patients, where you don't need to wait for any part of specific treatment like waiting for donor sperm or donor eggs. And that is the advantage of being a satellite unit, that you get the best of both the worlds. Now, to understand IVF treatment, it is very important that we understand what a normal menstrual cycle is, because your IVF treatment is just a play of your hormones. Now, in a woman who has a 28-day cycle, it is very important to understand what happens physiologically so that you understand the treatment process better. Now, normally on the first 3 days of the period in any woman, the follicle stimulating hormone, which is the FSH, and this is one of the tests which you do on the first 3 days of the period for FSH, LH, and estrogen. So the level of these hormones is the least on the first 3 days of the period, because there is no egg production activity taking place in the ovary. In the first 3 days, gradually there is a signal from the brain to increase the secretion of FSH to encourage egg production. And over the period of next 10 to 14 days, there is recruitment of follicles naturally. And one of the follicles will grow faster and reach a certain size around 16 to 20 millimeter on an average. And this follicle, which is getting ready, is going to produce the hormone estrogen. This estrogen in turn will act on the lining of the womb to build the lining of the womb in preparation for a prospective pregnancy. Once the estrogen levels are at a critical stage where the follicle is ready and the estrogen levels are high enough, it triggers a release of luteinizing hormone or LH from the brain. And the function of this luteinizing hormone is to act on this follicle where the egg is going to be ready, and it will release the egg into the pelvis. Once this egg is released, there may be fertilization in the next 24 hours because that is the lifetime of an egg. And the part of the ovary from where the egg has been released will change itself into a gland, what we call as a corpus luteum. And this gland produces progesterone, which is the hormone to support the lining of the womb to encourage growth of a pregnancy. So your IVF treatment is an interplay of all these hormones. So the basic medication during IVF is FSH in a high enough dosage that instead of producing 1 egg, we encourage production of around 10 to 15 eggs. We give you a trigger injection when your follicles are ready to release those eggs. And we also give additional medication to stop these eggs being released before you reach egg collection. Subsequently, once the embryo has been put back in, we support you with progesterone, pessaries, or injections to help growth of the embryo in its natural environment. So there are 2 types of IVF cycles. One is a long protocol and one is a short protocol, and there may be variations of each of them. With the long protocol, we Start the treatment on the 21st day of the previous cycle. The reason it is started on the 21st day is we want you to have ovulated by the time you start your treatment. On the 21st day, you will have a baseline scan to check whether ovulation has taken place. Make sure uterus, ovaries are all okay. There are no untoward findings. And if everything is okay, you are deemed to be ready. You will start with injections to switch off natural egg production and ovulation. On an average, a woman will require around 2 weeks of injection for the egg production and natural hormones to be completely depleted to create a level playing field similar to a medical menopause. But this is temporary. Once we check in 2 weeks time that the lining of the womb is thin enough and the ovaries are quiet, we start the second phase, which is the stimulation phase. The stimulation phase involves giving follicle stimulating hormone in high enough dosage to encourage recruitment of multiple eggs, 10 to 15 on an average. Once these eggs are ready, on an average in 8 to 12 days time, we trigger the release of these eggs with an artificial LH injection called as Ovitriol. And generally, you are booked for your egg collection 36 hours after your trigger injection. So that will be in the central lab, which you may choose to be Leeds, Manchester. Subsequently, the partner will need to give semen sample at the same time. Eggs will be fertilized with sperm either with IVF or ICSI, depending on what is needed and planned. And 5 days after egg collection, on an average, majority of the women will have the embryo put back in, because that is the mean duration where we grow the embryos before we select the best one for a transfer. If you end up with more than one embryo which is good enough, then that will be offered to you for freezing for use at a later date. We give womb support in the form of progesterone pessaries, which is in addition to the natural progesterone which you may be producing to help encourage the growth of this embryo. In the short cycle, we work in a different way because there can't be one cycle for everyone, and we need to cater plans depending on the medical situation of each patient, because the treatment may need to vary. And some patients we may find that the long protocol is better. Some other patients we find the short protocol is better. And that would be evidence-based judgment on which protocol is suited for which patient. So that would be for the clinician to decide based on your investigations that which protocol would be suitable for you, and we would book you accordingly. Now with the short protocol, the treatment or the stimulation starts on the second or third day of your periods. So you will be coming in on one of the first 3 days of your period for a baseline scan to make sure your uterus and ovaries are all okay. If everything is good on the scan, you will be starting with stimulation injection, which is the FSH injections to encourage growth of follicles. To prevent spontaneous ovulation, you will start a second injection, which is going to protect you from releasing the eggs before you reach egg collection. So there will be 2 injections, and that is the same for both the protocols. But the way they work is slightly different. Again, the time required for the follicles to be ready will be 8 to 12 days, and the ovulation trigger would be given when the follicles are ready, and 36 hours after the trigger, you will be going in for your egg collection. The male partner will need to provide sperm at the same time. Eggs will be fertilized with the sperm, and the lab will contact you the next day, which is 24 hours after egg collection, to tell you how many eggs have been fertilized and when is the likely date for your embryo transfer. And you receive womb support in the form of progesterone pessaries to support the embryo. With the long protocol, the most common injection which we give to suppress your ovaries is Buserelin. This is a daily injection, and because it shuts down your ovaries, It does have occasional side effects in very few patients like headaches, hot flushes, night sweats, mood swings. But these side effects will go away with the next phase, because the initial phase, this is due to lack of estrogen. But once we start the stimulation injections, these side effects tend to go away. It is very rare that somebody will have problems with the injection, but every now and then we do see that that patients do sometimes have these side effects, and treatment for that is symptomatic. Now, this is what you might be seeing when you come for a scan. Unstimulated ovary may have these tiny follicles which you are seeing, and that is how a ovary would look like. The stimulation is started with FSH, and the primary medication generally used is Gonal-F. Occasionally, we use a different preparation called as Menopur, and again, this is clinically decided. Occasional side effects of these medications are nausea due to high estrogen and abdominal bloating, because normally a woman will produce 1 egg every month, but we are making you produce 10 to 15 eggs. So that means the amount of estrogen in the blood will tend to be higher, which may cause nausea type side effects. But these are basically natural hormones which you will be injecting yourself with. Subsequently, when you come for your scans, after the first scan would be around 4 to 5 days of injection, you will be seeing on scan these fluid filled sacs. So these fluid filled sacs are the tiny follicles which have not now started growing, which we measure. And these fluid sacs will contain the future developing egg from where we will be harvesting your eggs. Now, generally, I said it takes 8 to 12 days. So even though you may be having a scan on the 5th day, 7th day, it would be longer that these follicles are going to be ready for your egg collection. So generally, you would require around 3 to 5 scans on an average before we book you for your egg collection. So the trigger injection which we give from outside is Ovitriol. So this is similar to the LH which your body naturally produces. And this is timed 36 hours prior to egg collection. So more often than not, this is something which you take in the night after 8 o'clock, but the lab will be contacting you with a time for your trigger injection. And they will also contact you with a time for your egg collection, which will be 36 hours from the injection. So this is just a scheme on what happens at the time of egg collection. So this is the ultrasound probe. It has a needle guide. You will be given sedation or general anesthetic depending on the lab you go to. And the ultrasound probe with the needle guide goes into the posterior part of the vagina, that's the womb, and it is nearest to the ovary here. With the needle, we pierce the ovary and aspirate the egg in each follicle. And this goes into a tube which contains the culture medium for the egg. And then this tube is given to the embryologist to look into to see how many eggs are collected. So this will be done with both the ovaries. On an average, it takes around 15 to 20 minutes per collection. So prior to egg collection, the standard advice which we give is to be fasting from the night before. Generally, we say midnight. Intravenous sedation and pain relief is what you get in the lab prior to your egg collection, and approximately 30 minutes for the entire procedure. After egg collection, you would need to recover for 2 to 4 hours before you go home. And more often than not, once the effect of the anesthetic or the sedation wears off, you will need your partner to drive you home. So fluid from each follicle will be examined for the presence of an egg. At the end of egg collection, all the eggs are immediately transferred to an incubator at 37 degrees. Okay, so this is just a video on how egg collection is done in real time. So you can see the follicles and you can see a needle which is entering into each follicle. Okay, so they have aspirated the follicular fluid and they have flushed the follicle to make sure that they collect the egg, and then they move on to the next follicle by piercing the needle into the next follicle and repeating the procedure. So that's done for all the follicles which are a certain size and appear to be mature. So after egg collection, you will have some symptoms of discomfort for 1 to 3 days. So advice is to take simple analgesics like paracetamol, which you can take up to 3 to 4 times a day. If that alone doesn't help, you can also take codeine. There may be slight discharge. There may be a hangover effect. So these are normal symptoms which you need to be aware of. So you may want to take it easy for the first 2 to 3 days after your egg collection. I would now invite Marni to speak about the embryology part, and then I will continue this presentation. Do you want to?
Do I need to request control?
Do I need to request control? Allow. Yeah. So we have given consent to control. So
Okay, that's fine. Can you hear me okay?
Yeah, I can hear you okay.
Okay, fabulous. Okay. Hi everyone. So my name's Marnie, one of the senior embryologists from Leeds. As has already been sort of mentioned, we're possibly one of your choices where you could come for your treatment. So what I'm going to talk to you about tonight is pretty much the science behind embryology and what we do. So it might not be exactly the same if you were to go to Manchester for your treatment, but in the theory behind everything that we do, it should be pretty similar. And I think as time goes by, the two units are becoming a little bit more aligned with how we do things, so there shouldn't be that much drastic difference between the two. Obviously, you know, just bear that in mind. So I will be talking about Leeds and your experience with us, and the photographs and everything sort of are relating to Leeds. But you know, if you choose to go to Manchester, again, it's just to bear that in mind. As an embryologist over at Leeds, there's a team of 18 of us all together. So we have embryologists, which are those of us that deal with the eggs and embryos and sperm. We've got andrologists, which are purely sperm experts. And then we have some lab support workers. So when you come through to us, you will see there's quite a few of us that walk around in blues, and you'll see us at various stages through your treatment if you've not already met any of us. We don't get out the lab very often, so when we do like to be able to talk to patients. Obviously COVID means it's a little bit more difficult than normal. It does mean that if you do get the opportunity to hear one of us talk, we do tend to go on, so I will bear that in mind and try and be as quick as I can. We also get very excited about embryos, and I do like pictures, because if nothing else, if you don't listen to anything else I say, at least you've got some pretty pictures to be looking at for the next sort of 20 minutes or so while I do my bit. So the pictures on the screen in front of you are just as the embryo develops. Now, when you come through for treatment, the majority of your embryo transfers will be on day 5, and then this is the stage of the embryo that we would like them to be at that point. So this is the blastocyst, and we'll show you some pictures of that later on. But the embryo starts off as one cell when it's first fertilized, and then this is 2 cell and 4 cells. So this is what we would like day 2, going on to 6 to 8 cells on day 3, and then a morular stage, or which is a scientific term basically for a blob of cells on day 4, and then the differentiation of the cells turning into a blastocyst come day 5. So this picture here is the main lab at Leeds. You can just to sort of so you get to see where we'll be looking after your eggs and your embryos for you when they're with us. Various amount of equipment, as you can see, different flow hoods, so safety cabinets where we do all the work to make sure that the air is sterile while we're handling your eggs and embryos, and then different types of incubators where everything will be kept at 37 degrees in the right humidity, with the right CO2 levels and things like that. You can possibly tell if you look at the flow hood on the left, the light in there is quite bright white, whereas the rest of the lab is yellow. We do actually have filters on all the lights so that we filter out the sort of like the harmful rays. Obviously, if you bear in mind where an egg and an embryo normally live, they don't normally like the light, they don't normally see the light, so we try and keep everything as dark as we can. And all the windows, even though we've got a nice view out the back over some trees, they are filtered as well, so that the amount of daylight that comes in is reduced, and some of them even are completely blacked up. Okay, thank you. So when you come through, obviously a concern with a lot of patients, quite rightly so, is how do we know that what we've got is your eggs and your sperm and making your embryos? Different units have different procedures and different technology to back up manual witness. At Leeds, we use a system called IMT Matcher, and this is what you can see up on the screen. So each patient is given an individual barcode, and then we use like handheld devices to scan those barcodes on your wristbands, and those barcodes are on the dishes and the tubes that we use, and that's all met. And you know, you can see in the top screen there we get the match confirmed, or if anything has gone untoward, it would also sound an alarm, and we've got processes in place to deal with that. We also have to have manual witnessing for a lot of processes, because that's still a stipulation in the Human Fertilisation Embryology Act. So it's a law that for certain parts of the procedure we have to have manual witnesses. So sometimes you will have to say you identify yourself in front of several people, and that's A, because we're all slightly pedantic, and B, but also because that's what we have to do to try and keep you all safe. Thank you. So it's already been mentioned, you gentlemen will have to play your part on the day unless it's a surgical sperm sample that we are using, or you're using donor sperm. The gentleman out there will have to produce a sperm sample for us on the day of your egg collection. We tend to do this sort of as your partner is going into theatre, so that you know, it's sort of like utilising that time as best we can, as it were. It says here that the sample will be assessed before you can go home. It's slightly different at the moment because of COVID regulations, but ideally, even if with the COVID situation at the moment, trying to keep the numbers down on the unit as much as possible, we do ask you to not go too far away from the unit. So if there is a problem with how the sample is prepared, you are nearby, and we may ask you to produce again, or we may ask you to just come in and just have a chat so we can go through what potentially the issues are. Samples produced in the morning, we will prepare it in the lab, and then it will meet the eggs in the afternoon. And again, the timing of that is all strictly linked to when you have your late night injection. So everything we do in the lab has to follow a particular time pathway. One thing I will say at this point is if you are feeling that there might be too much pressure to produce a sample on the day, that's perfectly fine. We have, you know, it's not an unusual feeling, and all I would say is speak to the nurses at Halifax about it. They've dealt with plenty of patients before with those things, so you're not going to be laughed at and then or felt silly. What we can do is we can just arrange for you to get a sample frozen and pop a sample in the freezer, and then if there is any problems on the day, we can use that frozen sample, and it just saves you know, yourself, your wife, and you know, us at the unit sort of the worry and the anxiety that might come with that. So please do bear that in mind and speak to the nursing team if you need it. Thank you. So this is going back to the egg collection. So the video on the left is what we see down the microscope in the lab when we are past that tube of fluid with hopefully the egg in, and that's the egg being found. The still underneath the video is actually the egg, so that dark circle is the egg in amongst the cells. Now, At Leeds, we do sedation. We don't do general anaesthetic. So some patients are fast asleep throughout the procedure. Some are awake and talking. So it really depends on how you find it as to whether you will actually see this on the screen that's in theatre or not with us. We will communicate with the doctor through the hatch. So you can see one of my colleagues is sat at the flow hood through the hatch. The photo's taken from theatre. We do have legs. You don't always see them. We'll need to see our head poking through the hatch, but we're there, I promise. And we will shout through to the doctor and let them know if we're seeing any eggs or just cells. And there's that communication, so the doctors know whether they can move on to the next follicle or not. The schematic at the top, bit difficult to see, but hopefully you can get the idea of it. Is you've got the picture at the bottom of your 2 ovaries. So the stimulated ovaries with the dark areas that are the follicles that are hopefully growing those mature eggs for you. The row above that you can see hopefully is the eggs. So that's the number of eggs that are collected. Highlighted then above that is the number that are fertilized. So that's just showing that you may have a large number of follicles. We may not get an egg from every follicle, because some of them may be too small or too immature, or it might, be a little bit of a cyst rather than a follicle sometimes. So, there's several reasons why we don't get an exact number. We don't get 100% fertilization a lot of the time. We would aim to get around 75% fertilization. So there's going to be some decrease in your number there. Not all those that fertilize will divide and make that first division to the 2 cell, which is the next row up. Not all of them will then divide to the 4 cell, which is the next row up, and so on and so on and so on. And you can see the numbers dwindle. What we want, this is a very optimistic picture, because here this patient has got 5 very good quality blastocysts. What we actually want is just one good one. Anything above and beyond that, then that's brilliant, and that's a real bonus. But ultimately, our aim is to get you 1 blastocyst, so we can get 1 good quality blastocyst transferred back, and that's going to give you hopefully an overall good chance of a pregnancy. So we have that included just so that you can be aware when you're coming through that the numbers do dwindle, and that's perfectly normal. That's perfectly acceptable, and that's what we would see. Sometimes it's a steeper angle than others, but just have to see how that goes. Okay, next slide please. Okay, this is my favorite slide because it's just got the amazing pictures. So we can just sit and look at the beauty of this for a while, but you can see the bottom left is the egg, and sort of like a bit of a sunburst. So the egg is that circle in the middle, and then the cells around it are the corona cells, which protect it as it's growing in a follicle and as it's sort of coming down through the fallopian tubes. That is what helps the sperm, or it's what helps the egg stop too many sperm getting through, because they have to fight the way through that. So it kind of minimises too many sperm getting through. A bit of the survival of the fittest, because it's not easy going, so the sperm have got to work to get through. The picture at the top, the slightly bluey tinged one, you can see that the egg is there taking up most of the picture, and you can see those flecks are actually the sperm. So that's just to show you the size difference between 1 egg and 1 sperm. So it's just slightly amazing really how big the size difference is, and it gives you some idea of how much effort the sperm's got to put into to get to the egg and then bury through. And then that's what the electron micrograph photograph is showing as well. So that's the sperm burying through the zona of the egg, so the sort of like the shell of the egg, and as soon as the sperm starts to bury in, so if this chap on the right is the one that's going to get through, as he starts to work through that zona, a chemical reaction begins all the way around, which basically shuts the door on every other sperm. So that's the natural process for hopefully only 1 sperm getting through. Next slide, please. Okay, so with IVF, that's the standard treatment that we offer. So if there's a good number of eggs and the sperm is fine, then we would go ahead hopefully with just IVF. That is where we mix a certain number of sperm with each egg on the afternoon, pop them back in the incubator and leave them to get up to what they need to get up to overnight. And then we'll check up on them in the morning. ICSI, some of you may know that that's what you need to have already, or you may have, looked into it and know a bit already, but that stands for intracytoplasmic sperm injection. So that's where we, as the embryologist, would pick an individual sperm and inject it directly into the egg. This is in cases where there's been previous or poor or failed fertilization. So you've had an IVF cycle, but nothing has happened overnight when we've left the eggs and sperm to it. So unfortunately, we can't predict that in a lot of patients. It's sometimes, if a patient's only got 1 or 2 eggs, it could be expected that things could end up, slightly negative. But sometimes you may have lots of eggs and we just don't know. And it's something we try our best to avoid, but we can't always avoid it. Doing ICSI straight away on patients like that isn't always the answer either. So we do have to take that risk at some point with patients. Now, if your semen analysis shows that there is a problem, so if the count is low or the way the sperm is moving is poor, or you've got sort of antibodies, so that's something that starts going around in the blood if there's been testicular damage. So that could be a rugby injury, that could be surgery, things like that. You might have a high presence of those antibodies, and in that case we would want to do ICSI because they affect the way the sperm swim and bind with the cells around the egg. So if you've not got enough sperm, or the way it's moving isn't good enough, or there's a high presence of antibodies, then we would be concerned about going straight forward with IVF for you, and we would recommend ICSI. There's also how the sperm look. Now, you will get a morphology score when you have a semen analysis done. It's more common to have abnormal looking sperm, or maybe that's a bit of a harsh word, but less ugly, or not quite as picturesque as we would like. So it's more common to have, a larger number of those. We tend not to worry about that too much because we do find the way that we prepare our samples for IVF and ICSI, we tend to find that we can sort of weed out some of those. So unless it's a very, very, very poor morphology on its own, we tend to only use the morphology in conjunction with something else not being great. If we've not got enough sperm from the preparation, or if it's a surgical sperm retrieval, the numbers are just too low for us to consider IVF, so we would therefore have to go through for ICSI. And you will know, gentlemen out there, if you need to go through for a sperm retrieval, and I'm not going to mention it in too much detail at this point, because if you don't need it, then it's possibly best just not knowing. Okay, next slide, please. So this is a video of ICSI. So I know it's tea time, and I always feel bad because if you're planning on having soup tonight as a quick tea, I'm possibly about to put you off. So if you think this is a bowl of soup and the little black flecks that look like pepper on the top are actually the sperm in the dish. Okay, so the needle that's coming from the right hand side is the needle that's picking up a sperm. You see it's just gone up into the needle. It looked a bit harsh there because we actually have to break the tail of the sperm to stop it moving, and then we catch it, and then we move over to the egg, and another pipette's going to come down and hold that egg into place. Okay, so that's just basically like a straw in a Malteser, just trying to hold it still, or a, trying to keep a balloon still. With it being a sphere, what we want to do then is hold it still enough so when we've got the injection needle here with the sperm and we're going to inject the egg, that the egg's not going to move around too much. So you have a quick prod just to make sure that we've got the right plane in the egg, and then hopefully you should see coming down that pipette, here we go, is the sperm coming down. Once it's at the end of our pipette, we break through the zona of the egg and the urolemma, and then you'll see the sperm starting to go back up the pipette. That little whoosh is what we want to see. That shows that we've broken through that inner membrane. That's what we need to do to be able to get the sperm inside the egg. And then that's it, that egg is being injected, and that will get cultured on, and hopefully we will see what happens with that overnight. And we just do that to all the eggs that are mature. If the eggs are immature, even if we injected them with sperm, it's just not ready to interact with the sperm. So we can only inject eggs that are mature. Next slide, please. Okay, so again, just a bit of a pictorial diagram of what I've just been saying. So top row is your sperm that have been inseminated with IVF, so your eggs, sorry, that have been inseminated with IVF, left overnight, and then, you know, one lucky sperm's managed to break through. ICSI, again, as we've just seen, we put the sperm into the egg. By breaking the sperm tail and by breaking the membrane of the egg, those two things encourage the correct reactions to take place within the sperm head and within the egg itself to try and encourage fertilization. When the sperm naturally goes through into the egg, so it's a little bit misleading is the picture, they actually leave the tail behind. It's the head that's going in, and that's the information, the genetic information that's needed. So we're actually inserting all the sperm into the egg, but because we've broken the tail, we've kind of mimicked the process as much as we can do in the laboratory. Above day 1 there you can see that's a picture of a zygote or a fertilized egg, and it's got 2 structures in the middle of it which are called pronuclei, and we need there to be 2. We need them to be 2 because 1 comes from the sperm, 1 comes from the egg. If there's only 1, or if there's 3, 4, 5, what have you, then something's not gone right somewhere. It might be that the egg has activated on its own, but there's no sperm got in. If there's only 1, it could be that the sperm's activated, but the egg's not activated. It, you know, a number of reasons. If we start getting 3 or 4, the egg sometimes can go a little bit crazy, or if it's IVF, it could just be that those barriers, those doors haven't shut and a couple of sperm have got in. So when you get your fertilization phone call the day after your egg collection, that's the number of 2PNs, or the number of zygotes, number of fertilized eggs that we're looking for, and that's the number that we will give you. Next slide, please. Oh, and a pretty picture at the bottom. There we go. And next, there we go, thank you. So we will do your insemination or your injection at roughly about 4 hours after your egg collection. So 3 to 4 hours after your egg collection, depending on your case, and then we will look at those eggs around 16 to 17 hours up to 18 hours later. So you will possibly have your egg collection at 10 o'clock in the morning. We would inseminate at 2 o'clock, and then we would check sort of 7:30, 8 o'clock in the morning how your fertilization had gone. It says here 60%. I'm boasting, saying we'd like to get 70 to 75, but you know, obviously we want as many as possible to fertilize for you, and it really is dependent on the maturity of the eggs as to what the percentage is. Anything that is anything other than a 2PM, so that, like that last picture I showed you, cannot be selected for treatment because we cannot guarantee the genetic information that's within that as to whether it's normal or abnormal. Chances are they won't develop anyway, but we would exclude them at that stage for you. We will give you a call as soon as we've done that, so expect a phone call sort of any time from sort of 8:30 onwards the following day. If it's a Sunday, we tend to wait till 9 o'clock just because we're nice, and even if we're in on a Sunday, we feel that, you know, somebody should be getting a lie-in somewhere. We'll give you a ring and we will book you in for your embryo transfer. We will give you your time for your embryo transfer at that point, unless it's falling on a Saturday, and then at Leeds we tend to wait and we'll just to see if there's any egg collections or anything happening on a Saturday, and then arrange your time. But we will let you know and give you as much information as soon as we can. Next slide, please. So your embryos, while they're with us, will have a lot of hurdles to jump over. We will call you, like I said, on the day of fertilization check, and then unless we have to confirm or alter your appointment time, we won't speak to you until the morning of your transfer. Appreciate it's a long wait, but actually what we've found is that we need to just leave the embryos to do what they need to do and make that assessment at that point, so the morning of your transfer, as to what we've got. We've tried it before, whether we call you on day 2 or day 3 and we give you updates, and we found that sometimes we were giving positive news and then day 5 we had to sort of backtrack because things had deteriorated, or sometimes we would be on day 3 going, oh, really sorry, things aren't looking great, but let's just see how it goes. You spend 2 days worrying, we come in day 5, look at your embryos, and lo and behold, they've proven us wrong and everything's fine and dandy. So what we're trying to do by giving you that period of time with no contact is purely just to try and avoid the bumps in the emotional roller coaster for you and trying to make it as smooth and as easy as possible for you. I'm not sure what Manchester do, so if you do end up going to Manchester, you might get an interim phone call, or you might not. Sorry, I don't know what their latest is. Anyway, these pictures are just pretty pictures because it gives you something to look at while I'm rabbiting on. But you can see day 3 embryo top left, so nice 8 cells, looking really good. Beautiful blastocyst top right. You can see it's just starting to hatch out at the bottom. It looks like it's got a bit of a rabbit's tail, and that's perfectly normal. And then the bottom one is almost completely hatched. And this is something we occasionally see in the laboratory, but quite often won't happen naturally until sort of day 6 into day 7. So if your embryos don't hatch, don't worry. It's perfectly normal for them not to. Sometimes embryos just have a slightly different time scale and some of them go a bit quicker. But this is a natural process that they have to do to be able to embed into the endometrium. So if we see it, it's quite exciting. We all get a bit giddy, and that's about it, really. Next slide, please. So this slide still says day 3 or day 5. Leeds, we only do day 5. So that's that. We will select the best embryo for transfer. I've already said that we want the best one, or we want a good one for you to go back. We do sometimes put 2 embryos back, but not in many patients anymore. And there is information out there about the single embryo transfer policy that came in many years ago, where it was felt that the twin and triplet rate with IVF was too high and it was dangerous, and we had to work together across the country to bring that down. And I'm pleased to say that, you know, we've got that really well under control and we do really well, and it's not affected our overall pregnancy rates. What we have actually found is that if we put 2 embryos back in a patient where they really don't meet the criteria for it, they were the ones that were ending up with a multiple pregnancy rate. They weren't ending up with a higher chance overall of a pregnancy. It was just making that difference between a single healthy baby and a twin pregnancy that could end up with complications. And there's slides about that later on. So you will be consented to just having 1 back if it's your first cycle, if you've got good quality embryos, and if you're 40 or under. And even if you're over 40, if it's good quality and you've maybe got some to freeze or what have you, then we would possibly discuss just putting 1 back for you as well. If we can freeze, we will do, obviously, and we will let you know what we've got. Anything that's not frozen or transferred on day 5, we will look at again on day 6 and see if they've caught up or improved overnight. And sometimes we get some day 6 freezing as well. But we will obviously, you know, keep you all updated via the telephone at the different points with regards to freezing if you get that. The transfer procedure, again, you know, some of the clinical slides go back onto this, so I won't go on too much, but it is a very easy procedure. It's like a smear test, so it's not particularly comfortable, but it shouldn't be painful. You do need a full bladder, and that is the worst bit, and I'm sorry. But the reason we ask for the full bladder is because it just helps the clinician that is putting the catheter with your embryo in to the correct place. It just helps pass that a little bit smoother, takes out a few of the kinks that may be in the way. Once you're in theatre, you should be in theatre for 10 minutes, 15 minutes max. And, you know, you can see on the scan what's happening. You can see the embryo up on the screen, certainly at Leeds, before we load it into the catheter. So you get a bit of a feel with that. At the moment, unfortunately, in Leeds, we're not allowing the husbands onto the unit for the embryo transfers at the moment. So we are, you know, trying to allow patients to sort of take a photograph of the screen. But hopefully, as COVID really restrictions relax a little bit, then, you know, we'll try and get the men back up for moral support as soon as we can. Next slide, please. I think that's me done. Yes. Okay.
Annie, that was a wonderful presentation on the embryology aspects.
You're welcome.
So this is a video of how we do the embryo transfer. So that's the full bladder, and you can see the outline of the womb, and you can see the embryo transfer catheter, the bright bit. And sometimes you may see a flash when the embryo is ejected into the womb, and the catheter is then sent to the embryologist to check that the embryo has been expelled correctly into the womb. So normal symptoms after an embryo transfer, you may have brief pain, but it settles. And generally there is no specific advice about what you do after going home. But it's just symptomatic management. If you have mild pain, you can take paracetamol. Now, what are the major complications which we are concerned with IVF treatment? So there are two. One is ovarian hyperstimulation, where when we aim for 10 to 15 eggs, we end up getting more than 15, which is classified as hyperstimulation, and multiple pregnancy. So these are our two main concerns during IVF treatment. Now, our expectation when we do IVF is to get, say, somewhere around 7 to 8 follicles each ovary, which counts to around 10 to 15 altogether. But sometimes due to factors beyond our control, we may see that someone may be over responding, even though they may be on a lower dose of medication, where in this case, it is a picture of a hyperstimulated ovary where you can see multiple fluid filled sacs around 10 to 15 in number, and that is just from one ovary. So combining both the ovaries, it does make it around 20-25 follicles if you take it from that viewpoint. And this is what we label as hyperstimulation. Now with hyperstimulation, you may have symptoms of bloating. This is because of enlarged ovaries due to those follicles, each developing on their own containing eggs. There may be nausea, diarrhea, rarely breathlessness or dehydration. If there are any concerns, we advise most of the time that we see you for a hyperstimulation check. If we are concerned that you are likely to produce more than 15 eggs, we make a clinic appointment to see you to check your well-being. But obviously, if it is a acute emergency, you may sometimes need to take advice from the A&E. Now, the other worry which we have with IVF treatment is a multiple pregnancy. The recommendation nationally is to consider a single embryo to be put back in for the first 2 cycles, which is the standard recommendation. And the reasons we recommend not putting more than one embryo is that with a multiple embryo transfer, there is an increased risk of miscarriage, premature birth with twins or triplets delivering at a younger age, with its own problems of low birth weight, immature lungs, and increased mortality. We also see more congenital abnormalities as well as cerebral palsy with multiple pregnancies, which we would want to avoid. And pregnancy complications are increased, which may include raised blood pressure, preeclampsia, anemia, or kidney problems. So this is all what we want to avoid, which is why the standard recommendation made is to consider a single embryo transfer. And that is the national strategy where to minimize multiple pregnancy, we aim to reduce the twinning rate to less than 10%. But it is a known complication of IVF treatment, as even sometimes with one embryo being put back in, there is a chance of a multiple pregnancy, even though it is very rare. And we would always be discussing with you at the time of booking treatment or during paperwork, where we'll reaffirm the number of embryos which will be put back in. And that would further need to be discussed with the embryologist when you go for your transfer. Now, unexpected events. So if say 10 couples have IVF treatment, we would expect that 7 to 8 out of 10 times it would be straightforward, like how I just discussed about the the plan or protocol. But sometimes there may be unexpected events like cyst formation, which may delay treatment by a few weeks to allow it to go away, or sometimes it may need medication or surgical cyst aspiration. Sometimes we do see that the stimulation is not to our expectation, where we are expecting to get around 10 to 15 follicles, but we see that the follicle number is less. And most of the times that may be something which is unpredicted, because you do have preliminary testing done to evaluate your likely response. But in spite of the safeguards, sometimes the response may not be to our satisfaction. On the day of egg collection, there could be bleeding from a needle point. Very rarely no eggs, even though we may be seeing those follicles. No sperm in the ejaculate. And if any male partner is concerned that they would not be able to produce sperm on that day, then we strongly recommend that you consider sperm freezing electively prior to starting IVF treatment. So that gives you an additional insurance that in case you have difficulty producing a sample on the given day, you don't have a setback on that day if you have frozen sperm as backup. So that is always an option. And if you have any concerns, feel free to discuss with the nurse prior to starting treatment or with the clinician at the time of booking treatment. After egg collection, we may see unexpected events where we have collected enough eggs. The eggs look good under the microscope. We know the sperm quality is good, but there may be fertilization failure. So in spite of having a normal egg, a normal sperm, but sometimes the eggs may be unfertilized. But that is what IVF is about, where we come to know about events which we would normally not know. Now, this is not very common. Fortunately, it is very rare, but we do see sometimes cases of fertilization failure. Failure of embryos to cleave. So this is again something which you would know over a period of 1 to 5 days post fertilization, where the embryos are looked at under the microscope. And we find that sometimes the embryos have not developed to our satisfaction or have stopped growing. And that results in failure to achieve embryos which are good enough for a transfer. Or very rarely, if we don't get a good enough embryo by the 5th day, then it may result in a failed embryo transfer. So you need to be aware of such events. You may also encounter events where if you have hyperstimulated and produced a lot of eggs, then we electively decide that we fertilize the embryos and freeze them to allow you to recover over 4 to 6 weeks time from the hyperstimulation before we start again with a frozen embryo cycle. So that is something which sometimes you may perceive as a setback, but it is in interest of your safety that we look into those aspects and consider freezing the embryos at those points. Now I would invite Susie, one of our nurses, to go through the aspect about nursing and pre-IVF care.
Hello there, my name's Susie. So today I'm just going to go through sort of more of the basic things as sort of a reminder of what hopefully we told you initially at your first visit. And if you do want to have a look at any more of this, it will be on our website under preconceptual care, and hopefully you'll have had a booklet at some point about that. So to start off with, we'll just talk about BMI. So anybody who's having treatment, IVF, ICSI, on the NHS, the BMI does need to be under 30, and we will check that. So yeah, so we do need to look at our weight. Smear tests need to be up to date. We should, hopefully you'll have had reminders from your GPs, but we can't start treatment unless we have a smear that's in date. So please do just keep an eye on that and check that that's all up to date. Zika virus, we used to talk about that an awful lot. We haven't mentioned it so much recently, but we do still need to be aware about the Zika virus, and that is, you know, a mosquito that if it bites you while you're pregnant, it can cause baby to have birth defects. So if you are travelling, do be cautious about which countries you need to avoid. And if you were to go to those countries, we do advise that you don't try to conceive or go through treatment until you've done the time spent, got back for a certain time. Coronavirus, I think Dr. Chowdhury is going to speak to you about later, but basically, yes, we are sort of stating at the moment, just have a look at the Royal College of Gynecologists website, and things are changing constantly with that, so do just keep an eye on that. Diet, we do recommend that you all, ladies and gents, eat a good healthy diet. So definitely your 5 fruits and veg a day, a good varied range. Alcohol, we advise certainly no more than 1 to 2 units a week. Some specialists say none at all, some 1 to 2 a week. So just be cautious about that. And again, the same with smoking. If you are a smoker, please do try and stop prior to treatment. And, if you can't stop, please do try and cut down on that. Folic acid, we recommend that all ladies take folic acid at least 12 weeks before treatment and then 12 weeks into treatment. Yeah, and into pregnancy, should I say. So you should need to be taking 400 micrograms of folic acid unless you have a BMI of over 30, and then we recommend that you take 5 milligrams, which does need to be prescribed by a doctor. Just mentioning BMI again, sorry, I don't think I said earlier that if you're self-funded treatment, BMI can be up to 35. Vitamin D, we should be taking 10 micrograms of vitamin D, and that would go prior 3 months, certainly 3 months before trying and throughout the whole pregnancy. Caffeine, we ask you to cut down on caffeine. Always just be cautious. It's in coffee, tea and fizzy drinks and things like that as well, and chocolate. So we do state no more than 200 milligrams, which is about 2 cups of coffee or about 3 cups of tea. Okay, so back to so going on to treatment, pre-treatment visit. So when you come in for your pre-treatment visit, we will discuss sort of all aspects of treatment with you and go through all the consent forms. It's quite a big task, and it certainly does take about an hour and a half. We always ask that you both attend together for this. And we go through all the HFEA consent forms with you. We can chat about it and discuss research, training, and things like that. We also at that point will discuss with you whether you're a short protocol or a long protocol. I think Dr. Chowdhury mentioned that earlier. So we'll go through your actual individual program of what and when, etc. We don't really talk much about injections at this point. We sort of do mention it, but we do go through the injection regime with you when you actually start your treatment. So we'll also talk to you about that at that time, also about add-ons. You might have heard about add-ons, and that's your things like your embryo glue and your embryo scope. So again, we'll talk to you in detail about that then, and you can ask us questions about it. Appointment times. We sort of obviously try and work around you as much as we can for appointments, but obviously we tend to scan during the morning. Everybody sort of tends to want the earliest appointment, so of course not everybody can have the 8 o'clock slot, so we do try our best. When you do start your treatment, you can have quite a lot of appointments in a short period of time. So could come for a scan one day, we could say, right, we need to see you again tomorrow. So that may be difficult for work for some people. So again, that's up to you if you want to chat to your employer about it. I think for some people it is getting a bit easier now with people working from home, so you don't have to actually state where you are all the time, etc. So the next Wee is again a Zika virus. So again, I've mentioned that, but we do just, if you do want to know a little bit more, there's the website there for you to have a little read about that. We do have a support service for you. So obviously, once you start going through treatment, there is somebody available to speak to, you know, if need be in the middle of the night. So if something went wrong middle of the night, you know, you dropped your injection or something like that, or you lost some of your medication, we do have a 24-hour support service. So again, we'll give you the details of that when we see you for the paperwork appointment. We always want you to, you know, we're here for you at any point really. So we're always at the end of a phone. If you felt, you know, unsure about things, or you know, you got home, reread what we'd gone through, thought, oh my goodness, I don't understand that, you know, by all means ring us again. We're happy to help, and we'd much prefer, you know, to feel really confident and sort of know everything rather than worrying about it at home. And we do also have counsellors on the unit which are here and available for you if you so wish. Have counsellors available for you, and you know, if you want to have a chat to us about that, we'll certainly point you in the direction, but again, that's just between you and the counsellors. And we do evening appointments, and they are obviously specialised in fertility, so they're to support you. So now we're just going to go on to the next part, which is our patient experience.
Hi, I'd just first like to say thank you to the team for letting me still pop a video on here to hopefully help with any hints and tips for going through the IVF process. Myself and my husband Lee were patients at Calderdale for quite some time, and this is a really strange situation to be in. I wish it could be different, and we could all be in Calderdale seeing each other face to face, but here we are. I hope you're all safe and well. So the team asked myself and my husband, but he doesn't do talking, does Lee, so he's not going to be in the video, to share our experience going through IVF. And I think it's quite safe to say there's no right nor wrong process. This is just our journey, and I hope it helps before you set off on your journey through the process. When I sat and watched Mr. De Bono and the team talk about the process and what was going to happen, it was just so overwhelming. I couldn't believe that anybody in the world could get pregnant. Was for the first things, it just seemed such a miracle for it to even happen. And also just the fact, the other thing that resonated with me, that doing this process wasn't going to be 100%. I really thought it was, and but actually it really isn't, and that was really grounding for me and my husband before we started off the process. And I think it just really cemented the fact that we just wanted to do everything we possibly could and listen to the advice that the team gave us to make sure that we gave ourselves the best possible possible shot, really, at potentially having a child. I think my first bit of advice would be just to talk about these kind of tough things with each other first, and before you start the process. So I think the things for me were, who were we going to tell? Were we going to tell anybody that we were doing this? Because, you know, you take them along the roller coaster with you, and, you know, it's great if it works, but if it doesn't, you know, there's pain there for, you know, your loved ones as well. We personally did tell family and a couple of close friends, more because I think I was quite clear that I think if we got any negative results, I just wanted to be able to lean on the people closest to me, and that really worked for us. I think the other thing is, how many times are you going to actually do this? If you're using your NHS, then you've got how many goes could you have there, but there's a potential that might not work out, and that you might need to pay, and you've got to both be on the same page, because when you're in the mix of it, you'll rule with your heart rather than your head, and you know, you want to both make sure that you know exactly what you're setting out to do. I think the other key thing for me was at work. I mean, I did share with my boss, and we didn't have an IVF policy at the time, but we do now. And it more because I just wanted support through the fact that appointments are just when appointments are, and then there's throughout the process of the cycle, you can have quite a few appointments every other day, and you know, being able to have a supporting boss and a company that lets you go to those appointments is paramount, really, and just really helps if you've got somebody there to lean on. I couldn't wait for the first call when we were gonna start. I was also terrified. I was so scared of starting with the needles, but I couldn't wait till start. I took the first injection in the hospital with one of the nurses, and I was literally stood there ages because I just couldn't shove the thing in. But it wasn't that bad. It was, I'm sorry, cat. Sorry about that. But yeah, I just couldn't do it. And my husband had no sympathy because he's diabetic, so he's taken injections all his life. So I just said, you've got to get over it, which you do. One of the things was, you know, every injection was just an injection closer to hopefully everything working. So you do them, and they do become really routine. Think about injections and when you start them, when you're going to have when you're going to take your injection, because if you're a shift worker, you might not want to be taking them into work and things like that. So just really think about before you start when's the best time really for you to have your injections. Mine was at about 6 o'clock, just purely because it meant I'd finished work, got home. It was just an easy thing, and then if we were doing something, it's done before you go wherever you're going. So that kind of worked for us. But then you start really with the injections, and it's the measuring. I was obsessed. I was obsessed with whether or not everything was growing, I wonder how many little follicles are growing, and what size they were, and I got a bit obsessive, which I know the guys will tell you not to kind of read up on things, but you do, and everybody Googles, and I was just like, oh, you know, I did everything possible. I was doing star jumps to try and get extra oxygen around my body to make these little eggs grow, but you do find yourself doing strange things, and I think the thing is, you know what, you're not alone. That, you know, that is natural. The getting to the right size was brilliant, and I think then having the primer injection was the bit that really just was. I was so nervous I was going to not take it at the right time. So Mr. Bonald will have said, you know, depending on when you're going to get your collection, depends on when you take your injections. So I'd set like a few alarm clocks just to make sure that I absolutely didn't miss out. We were over in Manchester. I did, you know, we both did a couple of dry runs going over to Manchester before the collection, because it was like, just wanted to really know where we're going, you know, what we're doing, so we're not late. And if anyone else is in Manchester, there was a little Sainsbury's, and we used to sit in there a little bit before we got in there, just because we just were super early, just to make sure that we weren't late. But egg collection was all right. Egg collection, actually, the sedation they give you is fabulous. You don't feel a thing. It was really quite straightforward. We had our Lee's sperm was frozen, so we didn't really have any of that pressure to think about it at the time. So it was just really about having the procedure, really. But yeah, a bit bloated, a little bit uncomfortable afterwards, but honestly it was it was nothing to worry about at all, and you know, you'd taken really good care of. The next day, still a bit weary from the sedation, so when they rang to give us the first the numbers of how many we had and how they were dividing, I didn't really take it all in, so I made sure that I had a pen and paper to write down just exactly what they said and then go back to it afterwards. It was pretty disappointing for us. We had everything else went really quite smoothly, but we actually only ended up with 2 embryos, and I was really upset about that. I was really, in my head, I thought, oh, I hear people have 8 embryos and 16 embryos and all that, and yeah, that was quite upsetting. But I was given the advice that, you know, you only need 1, and that's right, you know, you do only need 1, but, you know, it's just prepare yourself that, you know, it's not always huge numbers. The most important thing is that you've got an embryo. So we went in for the transfer. The transfer is just like it's just like really going for a smear. It's a bit uncomfortable, but you know, to be honest, it doesn't really matter what you're there for. And you just that overtakes it really. You get to see what's going on. You work through that procedure and they'll do the transfer. And in Manchester we were given a picture of the embryo that they put in, so that 2 embryos, we had 1 put in and 1 frozen. Then the worst bit, the 2-week wait. This was just an absolute nightmare, and that's when I really did start googling, you know, was I pregnant, wasn't I pregnant, you know, and it does send you a little bit loopy. I think the thing for me was try to figure out some stuff to do in that waiting time and to help occupy your mind. It won't take it away, because it just doesn't. You know, it is still always there, but if you can do some nice things together as a couple and that while you're waiting, that is it does help. And then also think about where you're going to be, because you go on for your blood test and then you'll get a phone call to say whether you're pregnant or not. So really think about where you're going to be, whether you're going to be together. You don't really want to be in Tesco's for, you know, doing shopping, or you know, you really want to consider where you are going to be when you get the news, whether that be positive or negative. So we got the first phone call, and just nothing, not pregnant. I just couldn't get over it. I just could not understand how everything went so well, so swimmingly, and no, you know, just no pregnancy at all. And I think that was a real difficult one, because you want something to be not right. But you know, we did an embryo frozen, so you know, we to go again, and that was it really. So again, all the process, went through it all again, right down to it's a little bit different because it was for the frozen embryo. Obviously there's no collection this time, so you're just doing your transfer, and that time, pregnant, we got the phone call, absolutely over the moon. I couldn't, you couldn't pick me off the ceiling. We were just so happy. And I think that was it. You know, it was just one of those things that you just think, finally, and after all that, you know, hard work, that, you know, we've got this reward. But unfortunately it didn't last, and sometime later, I'm still getting upset about this, we had a miscarriage. One of the, you know, the hardest moments that we've ever had to go through, but you pick yourself up and we learn so much. I've never been pregnant before, ever, so that was a massive tick. We could get pregnant, and I think you've got to take these learnings, and the team were fantastic. Like I said at the beginning, we'd been through with each other what we were going to do, and we knew we were going to pay for another go. So we were both on the same page there, and And we spoke to the team, and because we understood my body a bit more, I could increase the drugs a little bit, and so we started the process again. And this time when we went to egg collection, we had a few more eggs, ended up being a few more embryos, and we come out with 4. So we put 1 in and froze 3. And went through that process again, but this time we were absolutely ecstatic again when we got you pregnant, and with a smooth pregnancy, and then with no medical intervention at all. She arrived on the kitchen floor in complete style. And normally when I get to come to Colesdale, we show a picture of Poppy, but since we're at home, she is here, so I am going to shout her so you can see her. Poppy, come here please, darling. Just want you to say hi. Come here.
Hi.
And this is Poppy. So, Poppy is how old?
3.
3. And then this wasn't the end of our journey. Those people that, you know, if you've got questions about frozen and fresh cycles and the differences, we went back again, and embryo number 2 didn't work, but embryo number 3 did. And this is Hudson. Can you say hello? Can you say hello?
Yes. It's my sweetie of the line.
That is your sweetie.
Yeah, because it's very long.
It is very long. I think what we just want to say is that we wish you loads and loads of luck, and we hope that you get the perfect ending that we did. So are we going to say bye, everybody?
Bye.
Bye. Thank you for having us.
And this was one of our patients relating her journey through the IVF process. And it's really amazing to see each patient's journey, and it is unique for everyone. So one additional point which I wanted to discuss was regarding the COVID vaccination, because there are a lot of questions regarding COVID vaccination. The general advice is that COVID vaccination is an individual decision. And if you want guidance regarding decision making, we would advise you to check the Royal College of Obstetricians and Gynecologists webpage. So they have a dedicated web page for COVID vaccination in pregnancy, in women who are trying to conceive. So please go through those FAQs, if I may call them, and they will cover most of the scenarios. And if it is an individual decision, you also need to be aware that the recommendation from the labs at the present time is that we consider avoiding vaccination during your treatment, as well as 7 days leading up to the treatment. This is the general advice which we are giving couples, because we don't know the impact of vaccination during ongoing treatment, but you are perfectly okay to have the vaccination leading up to the treatment, as long as you are aware of your windows, that you refrain from having the vaccine 7 days from the 7-day window which starts with your treatment cycle, and that I mean prior to your treatment cycle. So that would be the general advice which we would give you, but doing the vaccine or not doing the vaccine is an individual decision. So please refer to rcog.org.uk for further information on vaccination. Now, I'm going to go through the questions. So please feel free to follow us on social media, because we are quite active on social media, and I'm just going to look into the questions which have been asked up till now. So one of the questions which was asked was, what is the waiting time from booking to treatment? So presently it is 3 to 6 months, depending on what treatment you need. The next question is what happens if treatment is on the NHS and either no eggs can be collected or none survive? Would that be our one go on the NHS done, or would we get another chance? Now, this is a difficult question to answer. Now, if we were not expecting your eggs to be not fertilized, or we were not expecting to get any eggs, then obviously if it is an accident or it is something which was not predicted, we would look into it whether we can provide you another cycle on the NHS, because we want to be fair to you. But if prior to starting treatment, we already know based on your egg number or your egg reserve that you are likely to struggle to get even one egg or two eggs, and there is a strong possibility that we may not get eggs which you have been made aware of prior to starting treatment, then in that case that would indeed be your NHS go, because you have made an informed decision to go ahead with treatment based on clinical advice as well as your own decision making. The other question. Excellent. So if there are any more questions, so these were the only two questions which I had today. But if you have any more questions, please feel free to type, and I can answer them in the next few minutes. Okay. I can't see any more questions, but we will be trying to organize these and give prospective dates for these evenings every 6 weeks from now. And we will also try to publish a link beforehand so that you can feel free to attend if you want to go through it again, and feel free to ask questions at any point of time. If you want to not ask questions in this common forum and you want individual discussion with any of the doctors or nurses, feel free to contact the unit and arrange an appointment to speak with me or any of the clinicians or the nurses. The same way with counseling. If you feel you need support in the form of counseling, feel free to contact and take advice from the counselors. And okay, so I just have a question. Can you be called sooner than 4 to 6 months to start? Yeah, yes. If obviously the waiting list starts moving faster with changes in the COVID scenario, then that is a distinct possibility. But that is for time to tell us. We can't predict that with the COVID challenges which everyone faces, and it's a changing scenario, so can't be predicted. But obviously, yes, if we can get more patients in, then we would consider going down with the waiting list. So that is definitely possible. So I think those were the main questions which were today, and we look forward to hearing from you over a period of time and answering all your questions. Thank you, Marni, for joining us. And it was a wonderful presentation. So we look forward to seeing everyone soon, and we wish all the best to everyone for their IVF journey. Thank you.